Apologies for the delay. There was a bit of confusion. First of all, I am not Laura Rosales. My name is Maria Ferres, and I want to thank Dr. Cotanco and Dr. Rosales for allowing me to moderate this session. By training, I'm a pediatric nephrologist, but I consider myself an adolescent and young adult specialist. And the topics that will be discussed are near and dear to my heart. There are some things I wanted to say while our speaker gets a mic. It's a difficult time to speak after lunch, people say, but I always love to have a session after lunch because, one, I know your brain has fuel, and two, it's a challenge for us to keep you engaged. So I know we're going to do that. I have to say a few words of thanks to the organizers of the RRI Conference. It's the 12th year that we have had a pediatric program, and we have gathered nearly 200 fellows over the history of our pediatric conference. So I want to acknowledge the pediatric attendees. I want to yay! Go little kidneys. And it's important because we're the team that receives those babies that are born to mothers who have end-stage and CKD. So we're looking forward to this presentation. I would like to give a couple of housekeeping comments. There was a problem with asking questions. Please start and reconnect to the Wi-Fi because it's not very strong. So if you're having difficulty sending your question or participating in polls, please reconnect to the Wi-Fi and restart the app so that you can be an active part of this. Send us questions early and often. And the last thing I want to tell you is I want to thank you on behalf of Crystal Johnson and all the organizers for everybody participating in this Clean the World effort. We have filled all the kits. We are sending messages to the people who will receive it, and that was a fantastic idea. Now, those are all the housekeeping comments. I want to introduce our first speaker. Do you have a microphone yet?
I'll speak there.
Okay. So Professor John Johns is a physiologist who heads the laboratory in Translational Intensive Care Medicine at the Erasmus Medical Center in Rotterdam. And he's going to talk to us about microcirculation, physiology, pathophysiology, and its clinical applications. Thank you, John.
Delicious. Thank you very much, Dr. Cotanco, for inviting me to come all the way from Holland to here. I'd like to talk to you today about the microcirculation, which I believe is the essential compartment, physiological compartment underlying renal disease. And I work as a physiologist in the Department of Intensive Care Medicine. These are my disclosures. My most important disclosure is that I'm a physiologist. I'm not a clinical doctor, so I can say what I want, and it'll be politically completely and totally incorrect. So my job here is to make you feel uncomfortable, and hopefully to make you think about what you do in a daily practice in maybe a different way. So let's just start with the cardiovascular system. Its purpose really is to provide the microcirculation with oxygen-carrying red blood cells, to transport oxygen to the cells for oxidative phosphorylation. We all know that. But what do we need it for? Well, for producing ATP. Most people know that too. But what do we use our ATP for? Well, more than 80% for the sodium-potassium pump. Our whole cardiovascular system has one purpose, that's to feed the sodium-potassium pump. So in shock, it's a physiological, a cellular definition where the oxygen being transported to the cells is insufficient to meet the metabolic demands of the cells. It's a yin and yang. It's a supply and demand. It's a cellular definition. And sure, hypotension causes tissue hypoxia and shock, but you can also have shock in the presence of completely normal systemic hemodynamic variables, as I will show to you. And the kidney in renal disease is in shock. And we know that from a number of studies, for example, the BOLD studies, which have shown that tissue hypoxia occurs in kidneys, and that it's got a very bad prognosis in chronic kidney disease, and especially in acute kidney injury, where Contrast-enhanced ultrasound measurements have been done, which we also do. You can also see abnormal cortical perfusion, and abnormal microcirculatory flow and oxygen transport is a key characteristic of renal disease. But it's more complicated than that, obviously, because it's a number of different pathogenic mechanisms all coming together, which is why there's no such thing as a magic bullet. And this is a block diagram for acute kidney injury, which has got an inflammatory component. This is the toxic triangle, which we've called of oxygen, nitric oxide, and oxygen radicals. Under normal physiology, these are well in balance, homeostasis, we call it, but when inflammation comes, all of this becomes unbalanced, and this results in a dysfunction of the microcirculation, which causes tissue hypoxia and results in acute kidney injury. So you don't need a magic bullet, you need a magic machine gun to address all of these different pathogenic components. And it really all happens in the microcirculation. And the microcirculation is an organ, much like the kidney is. It's got specific phenotypes, and it really has been very difficult to measure this clinically. So if we look at the circulation from a physiological point of view, we know, I don't know if I can have a pointer here, but I will do my best. I don't see it. There's no pointer, okay. Well, then you'll have to go with me. So as you can see, the cardiovascular system is a parallel system. So it's quite surprising, actually, that just with a venous measurement and a arterial measurement, we can say something about what's going on in all these different organ systems. So we can see this pulmonary circulation, this systemic circulation. Regional circulation becomes already a bit difficult, and the microcirculation and ultimately the mitochondrial oxygenation are something we know very, very little about. So to study the microcirculation in clinical scenarios, this was really what was happened for many, many years. Looking at the nail fold, vascular surgeons used to do this. They used to look up on the right there, you see small capillaries in the nail fold, and the less that you had, the more vascular disease that you have. This was the only methodology which was available for measuring the microcirculation in clinical situations. At the end of the last century, we introduced handheld microscopy to clinical medicine, specifically in surgery and in critical care. As you can see on the top, this was a photograph that was published in Wall Street Journal. It was a big thing because for the first time, we could visualize the microcirculation in the brain of patients undergoing neurosurgery. And as you can see here on the top left, we could look at brain tumors. On the top left is a normal cortex, and then a glioblastoma, a meningioma, and a metastasis. We looked at subarachnoid hemorrhages, at leukemia, and as you see, we published very well. In most of the bedside measurements, however, we measured underneath the tongue. And underneath the tongue, as you can see in this angiogram here, is a very, very convenient place to measure because it's in between your brain and your heart, and now more than 600 to 700 papers have been published looking at sublingual microcirculation and its meaning. We developed better cameras. This was a battery-operated camera which went to Everest a number of times, and this is the most recent version of the camera that we have used. And as you can see, you can actually track single red blood cells one by one. And we've applied this in many conditions. In intensive care medicine, it is a well-known technique now. As I mentioned, more than 600 papers. Consensus guidelines have been published. Here, this is one of the European Society of Intensive Care Medicine, published recently. And this is what the microcirculation looks like when you look underneath the tongue. And as you can see here, I can't point, but you see basically two going into one. That's the venous effluent. And if you look carefully on the top right, in the little loop there, you can see white blood cells as they roll through the venous system. So if we look at the phenotype of this microcirculation, there are two important parameters. One is the convection, or the velocity at which the red blood cells enter the field of view, and the other one is the density of the vessels. Everything that you see as dark is red blood cells. We use hemoglobin as an optical contrast agent, so we're looking at functional parameters here. Important to notice is that convection is, of course, something that resuscitation medicine always makes use of. However, diffusion, which is the distance from one of the vessels to the cells, it's really, I wish I could point, but I can't. So the larger the distance, the longer that the diffusion distance is, and the worse that it becomes in terms of oxygen transport. So there are two major phenotypes. One is the convection, as I mentioned, which is the velocity of the red blood cells, and the other one on the right side is the diffusion. And the diffusion distance is something that really cannot be measured in any other context except by this, because it is defined by the vascular density of the vessels in here. So in heart failure, you've got a normal diffusion, all the vessels are filled, but a low convection because of abnormal heart. And in Hema Dilution, you've got large distances due to the dilution of the blood and basically normal convection. And this translates itself to the function in the different organs. So if we look at the oxygen need of the different organs, like for example the heart in the middle, and if you look underneath at the bottom one, you see a small line that's 10 micrometers. So there are like 3 or 4 blood vessels in 10 micrometers. So the diffusion distances are extremely short in the heart due to the large oxygen extraction that the heart requires, in contrast, for example, to the liver, where the same line is 50 micrometers. And in the muscle, you see they're all lined up in parallel to the actin-myosin filaments. So this is the functional morphology and heterogeneity of the microcirculation in the different organs. And this translates itself to the susceptibility to anemia directly. And the kidney is the most susceptible. And here we see what happens when you start to hemodilute an animal and look at the oxygen availability in the different organs. You see on the top left that you can always go down to a hematocrit of about 10% before the oxygen comes into supply dependency. And that's because of these short diffusion distances. The kidney, on the other side, already starts to go into oxygen supply dependency at a hematocrit of 30. And that's why the kidney is so vulnerable to hypoxemia. So what we have done, this is a paper which was just published this year, to make these measurements more susceptible at the bedside and applicable at the bedside. We've developed automatic analysis software which allows us to measure directly and titrate therapy at the bedside. And we've done many methodological developments of this. This is the clinical validation, which is almost being accepted in critical care medicine at the moment. And whereas it takes approximately 400 hours to measure these 300 patients that we had in this validation paper, this software actually did it in 42 minutes, allowing a bedside measurement of this system. Not only that, but we can extract the diffusion and the convection component of the microcirculation and are able to identify the different pathophysiological mechanisms associated with different disease stages, such as sepsis, low cardiac output, and septic shock. And also, we can identify which of the different variables actually affect the convective and the diffusion capacity of oxygen transport. For example, on the top right-hand side at the bottom is a left ventricular assist device, which is very effective in improving convection, but does nothing with diffusion. Anesthesia, on the other side, due to its vasodilatory properties, is able to recruit the microcirculation but does nothing for the convection. If you put a little bit of nitroglycerin underneath the tongue, you can get the maximal availability of your microcirculation, and that way you can identify what the maximal recruitable microcirculation is underneath the tongue. But we can also identify leukocytes, and this makes the technique even more interesting because it's the only technique which allows a hemodynamic evaluation together with an inflammatory status. And this was the validation paper, and as you can see here, we're very able to track leukocytes and have done many clinical studies relating to leukocytes. So this is sepsis. And as you can see here, in sepsis, you have both a problem in convection and in diffusion, large areas where there are no red blood cells, and other areas where there is flow. And if you now start to treat septic patients with fluids, for example, what actually happens is that the patent vessels just start to flow faster, but do not actually recruit all of the vessels, as you can see at the top left hand and the top right hand. And you can see that these plugged vessels indicating endothelial dysfunction, red blood cell dysfunction, persist. And this also explains the reduction in oxygen extraction deficit which you have in sepsis. And this is disseminated intravascular coagulation. All of these patients had completely, totally normal systemic hemodynamic variables. But as you can see here, again, you see this very heterogeneous picture, and this patient died 6 hours later with this image. And this is a cardiogenic shock patient who's been resuscitated with vasopressors, epinephrine, normal cardiac output, normal blood pressure, no flow in the microcirculation, also with a very bad prognosis. And this is the surface of a kidney. And you can see here the tubular microcirculation very well visualized, looking directly at the flow. So I'd like to present to you a case study of one of our patients. This is Sophie the pig. And what we have done here is a typical scenario which we would see in the ICU. The patient had a baseline cardiac output of 4 liters per minute, mean arterial pressure of around 94 millimeters, and as you can see, a lactate of 2, renal blood flow 360 milliliters per minute, which is great for a pig. Then endotoxin was introduced, the animal went into shock, everything went down, and the animal was resuscitated with fluids as would be normal in a clinical scenario, and was effective in improving the cardiac output, 3.6, mean arterial pressure is acceptable, SVO2 is acceptable, heart rate's a bit on the high side, we get uncomfortable with high heart rate, but the lactate is very high. And as you can see, this is a lucky pig because we could measure its renal blood flow down to 68 milliliters per minute. So here you see a completely normal systemic hemodynamic variables with high lactates. A lot happens in the ICU with this condition. And if we now look at the kidney in this scenario, that's what the kidney looked like. So to me, it's unbelievable that you can have relatively normal systemic variables and the kidney looking like this. So is there any other way that we could have known that the kidney was in distress in this particular patient? Well, we can look at the microcirculation underneath the tongue. This was the situation before. And if you look carefully, all of the blood vessels there are flowing. And after shock and resuscitation, with a normal systemic hemodynamic variables, this is what we saw. And if you look carefully, there are many plug variables on top on the right side, top on the left side, showing endothelial dysfunction, showing microcirculatory distress, and showing the systemic microcirculatory failure in this particular animal. So we have come now to understand that we have to look at this situation as a form of microcirculatory shock. What does it mean? It basically means that irrespective of the cardiac output, that your microcirculation is unresponsive. A disassociation, if you like, between the systemic variables and the microcirculatory and regional variables. And that this occurs in patients was shown very nicely by this study by Jacques Duranteau in Paris. He's one of the leaders of one of the largest emergency medicine departments. And what he did in his hemorrhagic shock patients, he immediately, when they entered, resuscitated them with blood and vasoactive compounds and fluids, as would be done normally. And as you can see at the bottom, heart rate, mean arterial pressure, cardiac index was all normalized. But as you can see on the top left-hand side, it took 4 days before the microcirculation was normalized. So you see here again a complete disassociation, and up on the right side, you see that those patients that took longer to come back to baseline had a worse SOFA scores than those that did not, SOFA scores being an organ function score which is used in ICU. And of all of the parameters, with receiver operating characteristics on the right, the abnormal microcirculation was the most sensitive hemodynamic variable predicting outcome. So this led us to introduce this concept, which we call hemodynamic coherence. It really is the expectation of resuscitation medicine that when you try to correct cardiac output or mean arterial pressure, that you expect all the organs and all the microcirculation in the tissues to follow in parallel with what you are doing with the systemic variables. But in practice, this does not always happen. And when there's a loss of coherence, such as happens in inflammation, you get 4 different types of loss of coherence, and this loss of coherence is associated with adverse outcome. The top left one, type 1, is this heterogeneous image which I showed to you in the septic patients. And this really is seen most likely in conditions of inflammation such as sepsis. And I don't know if you've seen this. This came out last week, and it's caused a great effect in Europe in any case, in which now it is clear that the death caused by sepsis is much higher than that of cancer, and here multiple cause of death. 109 individual death records were analyzed, and in year 2017, 48 million patients had sepsis, of which 11 million died of sepsis. So at this moment, sepsis is really a very, very major cause. And of course, acute kidney injury is one of the major causes of death by sepsis too. So this is a study on 500 patients showing again that abnormal microcirculation, much more so than mean arterial pressure, SVO2 or lactate, indicates is a strong indicator of adverse outcome than global systemic hemodynamic variables, especially this increased flow heterogeneity. And here we see again such a situation in septic patients, and you can see very well that there are shunting going on with some vessels in which there is perfusion, next to vessels which is complete stasis. It's obvious that just giving some vasopressors and fluids is not going to improve this particular situation, and other types of approaches are needed. Hema dilution I'd like to talk about because I think that is one of the most important iatrogenic causes of renal failure in perioperative and intensive care medicine. And if you look at the amount of fluids that are being given to patients, it's really amazing. Here's a paper which came out in intensive care medicine which shows that anything above 6 liters on a daily basis starts to increase the mortality. And what is surprising and shocking really is that the surviving sepsis guidelines, which are the major guidelines for sepsis, are telling you to target 6 to 10 liters of crystalloid, which is really chasing mortality in these patients. And another important thing to understand is that the administration of fluids causes iatrogenic anemia. Here we see in this paper 500 milliliters of fluids causes a decrease in hemoglobin concentration of approximately 1 gram per deciliter. That is a lot. We looked at our patients in our own ICU retrospectively, and if we take the World Health Organization definition of what anemia is, then anemia at admission to the ICU with a p-value of 0.001 was the most sensitive predictor of the incidence of acute kidney injury in this cohort of 5,690 patients. And it is logical. You need hemoglobin to carry oxygen. Here you see the amount of oxygen that is dissolved in saline. It is less than 2 or 3%. So hemoglobin is really the main component of oxygen transport in the tissues, and there are many physiology papers which actually show that. So instead of cardiogenic, hypovolemic, obstructive, and septic shock as being the 4 types of shock, we must also add to that anemic shock as a type of shock according to the cellular definition. And the only way to increase that particular situation is to give a blood transfusion. So getting back to fluids, we can measure the dilution of the microcirculation in these burns patients who receive a lot of fluids, and you see the total vessel density reduces when you give crystalloid resuscitation and recruits when you give albumin. And if you look at the focus depth also, we can actually quantify the edema which is present in the microcirculation. So this is an important slide because we wanted to understand what is going on with fluids in the body during cardiac surgery, for example. So we put a integrative evaluation of how fluids actually go into the body. We took a non-invasive cardiac output measurement, which is called a NextFin, a cuff, the microcirculation by our camera, and the Fresenius Medical bioimpedance device looking at the extra and intracellular water. And we looked at patients who had come from the ICU and that were volume overloaded. And on the top you can see what is going on. The cardiac index is higher, which is what you would expect if you start fluid loading a patient. That's the expectation. But if you look at the middle panel, you see that the microcirculation has been completely diluted. So more cardiac output, but at the expense of the oxygen carrying capacity of the microcirculation. The most interesting thing came out of the bioimpedance measurement, in which you see the weight of increase of about 10% in the patients. Extracellular water goes up. All crystalloid solution was just extravagating from the circulation into the interstitial space, but the most significant effect was the reduction in intracellular water. So crystalloids resuscitation was causing intracellular dehydration. And actually, this is something that is known already in the previous century, in which they looked at radioactive labeled water, and were finding that crystalloid resuscitation is causing intracellular dehydration, and that intracellular dehydration is causing intracellular protein breakdown. So we think this is really an important finding, and you can measure it by combining these three different techniques, which we hope to combine into one monitor. So how do you solve this problem of fluid overload? Well, you can de-escalate the patient, as is known after optimization. And here you can see very nicely on day 1 and day 3 that de-escalation by using loop diuretics, for example, causes a recruitment. It's one in the same place, day 1 and day 3, and you see that a lot more vessels, not improving the convection, but improving the diffusion and thereby the oxygen extraction capacity by reducing the distance between the red blood cells and the tissue cells. In hemodialysis too, you can see very, very well that hemodialysis causes hypovolemia. So on the left-hand side in this graph there, you see the MFI, which is the flow index. 3 is normal. Everybody here has got a MFI of 3. But you see that renal dialysis patients have got much lower normal flow in the microcirculation. When you do a Trendelenburg and lift the leg and do an autotransfusion, you see an improvement in the convection in these patients. At time point T2, the patient goes on to hemodialysis, and you see the incredible reduction in the flow of these microcirculation in these hemodialysis patients. If you then give a Trendelenburg position, you see an enormous response in the microcirculation. So this is a very, very nice and elegant way of demonstrating hypovolemia and the volume status in these patients on dialysis. And this is Yu Chang Ye from Taiwan, who we have a close collaboration with. They have a dialysis unit of about 150 beds, and they get their patients to do Tai Chi during dialysis. Very interesting. And we analyze a number of the patients, and as you can see, the dialysis patients have got a lot less vessels than do controls, and after transplantation, these are normalized. So there's another, and these are my final slides that I'd like to present to you. So you can de-escalate the patient to recruit the microcirculation, but there are, of course, a lot of toxic cytokines being released, especially in states of inflammation. And what you could do is you can remove the cytokines. So this is one of those filters, which is a cytosorbent filter, which removes, as it were, excessive amounts of cytokines. And we just published this paper just recently and showed a 28-day all-cause mortality improvement in the use of these filters. Now, these are patients that have got a SOFA score of 13.8. If you are a patient that has got that, you have an 80% chance of dying. There is no therapy in sepsis that actually does that. And is this propensity matched study, we're actually able to show an enormous improvement in the mortality in these patients. And this is Abella Donati, who did a microcirculation study in these patients and showed that if you remove the cytokines, also as you can see here, TNF going down, IL-6 going down, and you see parallel improvement in the microcirculation in these severely ill septic shock patients. So removing cytokines, de-escalating the patients are all issues which are beneficial for the patient. So finally, with our software and with our understanding of the microcirculation, we can now understand whether it's the diffusive capacity of the microcirculation or the convective capacity or a combination of the two, and what type of microcirculatory shock is present, and either using a combination of anti-inflammatories or fluids or red blood cell transfusions or de-escalation in having a differential diagnosis of the disease. And this was a study in which we have conceptualized how to use and integrate the microcirculation into routine clinical care of the hemodynamic alterations in our patients, to first use the macrocirculation to treat, of course, the macrocirculation if there's hypotension or any other abnormality, but then to measure the microcirculation and to see if there's been a parallel improvement in the microcirculation. If not, to do a differential diagnosis, and depending on the type of alterations and the type of loss of coherence, to then go to different types of treatments in the hope of recruiting the microcirculation. And this good friend of mine, Professor Wai Zhen Sun, who gave this beautiful calligraphy, says the true source of qi, which is energy, is the kidney. So thank you very much for your attention.